Good evening, everyone, and thank you for joining us for the next in our series of webinars from OCL Vision. To those of you joining for the first time, a big hello and a big welcome. And for all the regulars, hello again, good to see you back. I would like to personally thank you for all your feedback that we've had from these webinars. They've been fantastic and really much appreciated. And if anyone has any advice on what they'd like to hear next or who they'd like to see speak next, then please do email me and I'll be sure to organise that. So as you know, things have changed. I will no longer be uploading points straight to the GOC. Instead, you will receive a certificate so you can upload via your CPD, and that will contain your name and your GOC number as you entered it when you registered. This webinar is recorded and will be available to view along with our other webinars on our YouTube channel. So this lecture itself will run for about 45 minutes with questions at the end. There is one CPD point available for optometrists and dispensing opticians. If you do have any questions throughout the webinar, please do pop them into the Q&A box and we will get through as many as we can at the end of the lecture. So today's speaker, a very Mr. Popular, Shah Kashani. Shah is a consultant ophthalmic surgeon at OCL Vision who specialises in the management of complex medical retinal disorders. He performs intravitreal anti-VEGF injections, intravitreal steroid implants, anterior and posterior segment laser treatments, as well as high volume cataract surgery. Right, Shah, over to you. It's going to be a good one.
Thanks, Bertie. Always set me up, hopefully not to fail this time. So now let's say share screen. Yes, share screen. Yeah, okay. And I'm going to go there. Right. Well, thank you very much for joining. There will be an opportunity. We nearly have 500 people on the group actually. Hopefully there'll be some questions that we can have afterwards so that we can go through some of the stuff. I'm going to try and keep on to time. I'm sure a lot of you are tired and I've just come back from work. So here we go. So we're going to talk about retinal vein occlusions today. Here's my financial interests. So I've had travel grants pre-COVID, obviously, when we could travel, from Novartis, Bayer, Allergan, and my email address if you have any questions, and various other stuff. So topics today, we're going to talk about definition and terminology of different types of retinal vein occlusion, natural history and epidemiology, causes and risk factors, history examination and investigations, management of RVO, and really what happens when you send patients in, whether it's in the private sector or in an NHS setting, what kind of things would they expect? So definition, retinal vein occlusion is obstruction of the retinal venous system by formation of thrombus. And you know, there are essentially three different types. There's a central retinal vein occlusion, hemiretinal vein occlusion, and branch retinal vein occlusion. And at the bottom of your screen, you've got the various pictures. So you've got the central retinal vein occlusion here, hemi, as the name suggests, which is kind of half the retina is covered with hemorrhages, and then branch, which is essentially 1/4. So that's kind of easy enough. In central retinal vein occlusion, the thrombus is of the central retinal vein at the lamina cribrosa. And the typical features are swelling of the disc. You have hemorrhages in all 4 quadrants. And essentially, depending on how ischemic things are, you might have cotton wool spots, retinal edema, etc. And you don't always have to have disc swelling. So you may have situations where the disc is not swollen in less severe forms. And as time goes by, hemorrhages tend to resolve and you can get disc collaterals and venous sheathing if you see the patients later on. In hemiretinal vein occlusion, it's either superior or inferior. You've got a nasal and the temporal part of that hemiretina which has been affected. And essentially, one will look at that same as a branch retinal vein occlusion, and I'll come explaining that to you in a minute. And finally, in branch retinal vein occlusion, you tend to get the hemorrhages in a quadrant, as one might expect. Now, I've got a couple of videos that will try and explain what is going on. So just letting you listen to that. Hopefully you can hear it.
The cause of a central retinal vein occlusion lies in the close relationship that exists between an artery, which brings oxygenated blood into the eye, and the vein, which drains blood out of the eye. Because both are so close to each other in a narrow space, if an artery hardens, it can compress the vein. this happens, a clot can form in a central retinal vein. Once present, a clot can obstruct the vein, stopping the flow of blood out of the eye, which therefore limits the supply of blood into the eye. The insufficient supply of blood to the retina causes the release of VEGF, stimulating the growth of tiny, weak blood vessels throughout the eye. These new blood vessels are also at risk of hemorrhage and may cause other complications such as neovascular glaucoma. In its early stages, a vein occlusion can cause the vessels in the back of the eye to become dilated and tortuous as the pressure increases in the blocked vein. If the pressure gets high enough, the vessel walls can rupture and blood can leak into the retina. In addition to bleeding, serum, the fluid consisting of small proteins and lipids, can also seep into the retina. This resulting leak can lead to macular edema, a cause of visual distortion or visual loss.
Okay, so I hope you didn't think I was going to just leave you on and walk away. That was just, I think it's quite a nice way of essentially, visual way of understanding what happens in a vein occlusion. And essentially, just to go back onto this, the major cause of vision loss is from macular edema, whether it's branch, central, or hemiretinal. And the mechanics of it is that once you have vein occlusion, there is essentially hemorrhage in the retina, and the photoreceptors are starved of oxygen because they're not getting the oxygen that's around. And as a result of that, VEGF is released. And vascular endothelial growth factor causes further permeability to these blood vessels that are damaged, and more fluid comes. More fluid, more edema. The photoreceptors then get less oxygen, and as a result of that, there is more VEGF, and you've got this vicious cycle of more VEGF, more edema, less, more hypoxia to the photoreceptors, and everything goes up. Now, as you get macular edema, the photoreceptors are really stretched and distorted, and that's why the vision goes down. Now, that's one way which can affect the cells or the vision in the back of the eye, macular edema. The second way is if you imagine a blowout from retinal vein occlusion, you can essentially shear off photoreceptors from the RPE cells, and that in itself, that trauma of the vein occlusion can also cause reduction in vision. And that's why with anti-VEGF therapy, if you get rid of all the fluid, sometimes the vision doesn't quite come up how it should be because the damage from trauma has already occurred. And then the iron in the hemoglobin, which is around the photoreceptors itself, is toxic to them. So that's a third way in which vein occlusion can cause damage. Now, as time goes on, you can also have ischemia or in the back of the eye, and that in itself will kind of drive VEGF, but it will also cause new vessels. So we've kind of been through the macular edema kind of causation, and if you look on this side of the picture, you can see these hotspots on fluorescein angiography, and that's what you get between non-perfused and perfused areas of the retina. You get these abnormal new vessels, which can bleed and cause vitreous hemorrhage, and that will then need surgical treatment, etc. Sometimes it might go away on its own, sometimes it may not. But if these blood vessels then grow to the front of the iris, they can block up your trabecular meshwork, increase pressure, get neovascular glaucoma, and disaster. You know, you've kind of lost vision and lost the eye. So it is very important that when you see a patient with retinal vein occlusion, you do make an immediate referral, because macular edema can come on quite quickly. And whilst I'm not saying you might urgently start everybody on anti-VEGF, we do want to see the patients ASAP. Now, one thing that's really useful when you see patients with retinal vein occlusion is to actually describe it. So, you know, when you're making a referral, is it a central vein occlusion? Is it branch, or is it hemiretinal? Those things make a difference. I would worry more about a central retinal vein occlusion because they often have worse prognosis. And also, a lot of you now have OCTs, so we'd want to know if there's any established macular edema or not. And finally, the other thing that we would want to know is whether you feel that there's any ischemia or not. Now, ischemia kind of on presentation is sometimes difficult to kind of obtain, but in general, if the vision is worse than 660, if you've got deep intraretinal hemorrhages, that's not, obviously here you can see really hemorrhagic vein occlusion, that's a central retinal vein occlusion, but in branch or hemiretinal, you can get this as well. So if you've got very deep intraretinal hemorrhages, poor vision. RAPD is very important. We would want to see that. So does the patient have a relative afferent pupil defect? Because if they do, then it is ischemic. And this is very important because we it tends to affect the prognosis. So ischemic vein occlusions tend to do much worse than non-ischemic vein occlusion. If you've got a ischemic vein occlusion and the vision is very poor, you may even decide not to proceed with anti-VEGF therapy if the patient doesn't wish to go through an intense regime. With non-ischemic, you should always try anti-VEGF therapy if there's macular edema in order to try and give them the best chance to improve the vision. And of course, if they've got ischemic vein occlusion and they're keen to improve their vision, then that's fine too. On angiography, in essence, when you're in studies, 10 disc diameters of non-perfusion in CRVO and 5 in BRVO is counted as ischemic or versus non-ischemic. But don't forget, when it's very hemorrhagic, fluorescein angiography is often of very limited use. So, and the other thing that we'd like to look at is actually the fovea. So is the fovea ischemic? What's the size of the fovea? Is there, what's kind of happening around that? And that's also important, something we see with fluorescein angiography. But essentially, what type it is, what the vision is, obviously, is there any RAPD? Are there deep intraretinal hemorrhages, cotton wool spots? And that kind of makes us think, is it ischemic, is it not? And if there's any macular edema. And I said, most of you have OCT, so that'd be very useful for us. The other thing I would say is to recognize, and this is what we discuss with the patients, that up to 30%, so when patients present with retinal vein occlusion, 2/3 are in the non-ischemic good prognosis group and 1/3 are in the bad group. Often they're in the ischemic group, they don't go to the non-ischemic group. So the third that starts off badly will end up badly. But out of the 2/3 in the non-ischemic group, which have a good prognosis, 1/3 of them will become ischemic, and that is not affected by anti-VEGF therapy. And it's very important to warn these patients from the beginning that despite treatment and management and addressing risk factors, they have a 30% chance of still losing the vision in that time. So natural history, we know that because anti-VEGF therapy has been around since 2008 for AMD. For RVO, really, it was probably around from 2013 onwards. But people were using anti-VEGF therapy before that. Of course, observation is all we were doing. And essentially, 20% of patients were presenting anywhere between 618 to 660 with CRVO. Majority, even if they had spontaneously recovered, wouldn't see better than 612. And check this out, more than 90% of patients with ischemic CRVO end up with a vision of 660 or worse, which is pretty poor. Whereas in branchial vein occlusion, as I mentioned, it's a better prognosis, especially if it's not ischemic. A much higher proportion have vision of 612 or better at year 1. And 20 to 40% can improve the vision spontaneously without treatment, but vision doesn't often go beyond 612. So early treatment is quite important. The main prognosis with management of macular edema on how they're going to do is what's their starting vision and how quickly you can get patients on treatment. If you start treatment longer than 3 months, they don't tend to do well. So really, if they've got established macular edema, you want to treat them ASAP in order to give them the best chance of the vision that they can get. And 5% can be bilateral. So epidemiology, it's the second commonest cause of blindness due to retinal vascular disease, diabetic retinopathy being the commonest cause, and of course wet AMD is the commonest cause of blindness in the UK. 500 new cases of CRVO and 1,800 BRVO per 100,000 in the US. There's actually not that much in the way of great prevalence data in the UK. I'm not sure why. Maybe that's a project for somebody who is brave enough to take it on. But essentially, those are the countries. You see a lot more BRVO than CRVO, and it's very directly linked to age. So less than 1% under 60, and nearly 5% in over 80s will have some sort of vein occlusion. And as I said, you can get bilateral disease in about 5%. So it's very important to investigate these patients because they have a high, 5% risk of getting it in the other eye. And of course, if they do, then that's not good. What I'd want to know in the history when I see these patients in clinic is risk factors. So if you recall that video, the artery and the vein in the back of the eye are very intimately close to each other. And with retinal vein occlusion, it's kind of anything that affects the artery can compress the vein. And that's why we ask about hypertension, diabetes, raised lipids. Those three things tends to kind of cause atherosclerosis and affect the arterial side, which can then affect the venous side by compressing the vein. But within the venous side itself, you can have thick, sticky blood. So conditions like polycythemia rubra, we get high red cells. If the blood vessel wall itself is sticky, like in vasculitis, these are kind of risk factors for vein occlusion as well. Sometimes if the pressure is very high, as in glaucoma, I'm talking quite high pressures, that can compress the vein in the back of the eye as well. Because don't forget, the pressure in the vein isn't like the pressure in the retinal artery, it's at a much lower level. So if your IOP is high, you can compress the vein in the back. And then short axial length and retrobulbar external compression can also cause venous things. So although it's a venous occlusion, you do have to ask about arterial risk factors mentioned here, and then think how else can the vein block. So if you've got issues with coagulation disorders and inflammation of the veins, that can also be a risk factor. I've kind of just put up some facts here, which is kind of might kind of make sense to you anyway. But generally, development of rubeosis is commoner with ischemic central retinal vein occlusion, and then hemiretinal vein, and then branch, which kind of makes sense. But with new vessel disease, ironically, hemiretinal vein occlusion is more likely to cause that than ischemic central retinal vein occlusion. And just remember, if you've got a hemiretinal vein occlusion, the management is same as branch retinal vein occlusion. And I will come to why that is important in a minute, because we've only talked about anti-VEGF therapy, but there are other ways of treating this condition. Dehydration is quite important, especially in when we see a young patient. So I've seen a fair amount of central retinal vein occlusion in people who've done marathons, very healthy people, no risk factors, but extremely dehydrated, or the other spectrum. They've gone out on a big night out and had lots and lots to drink, and they've been very dehydrated and ended up with a vein occlusion. So make sure you have a very tall pint of water if you've been on a big night out. And within the eye clinic, it depends who you have in front of you. So if I've got somebody who is over 55, then really, as per Royal College guidance, I think it's actually 50, you just take a history as normal. I'd want to know what the blood pressure is. Often I ask the GP to do a 24-hour blood pressure because you can get variation. I think nowadays with COVID, they just ask them to buy a blood pressure machine and just do the measurements themselves and send it to them. But a 24-hour blood pressure would be ideal. And then blood tests are very limited, because I think in the past, any vein occlusion that was coming through, they were getting a whole array of blood tests, and very little was coming back as positive. So in the at-risk group, and that's kind of 50, 55 over, you only need a full blood count, ESR, and HbA1c. HbA1c is what you need to exclude diabetes, I'm sure you know. Full blood count is essentially for causes of coagulation disorder. So you've got very high red blood cell count, which can cause vein occlusion, and ESR is a very general marker of inflammation. But these patients are likely to have had other symptoms apart from their eyes. It's very unusual for an inflammatory condition to present with a vein occlusion and nothing else. So your lupus patients will have arthritis and skin rash before they come, and sarcoid patients may have chest problems, or they've been diagnosed with this conditions, and eye is the secondary thing. So normally the blood test would be abnormal if they're presented, if the eye is the first presentation. And then if they are younger than 50, or if it's bilateral, so if they come with bilateral presentation, then you do need to throw the book at them. And that does involve going through what I've just mentioned, but a full lipid profile. You do a serum ACE to exclude sarcoid, VDRL for syphilis. ANA is a much nicer way of checking for inflammation. And then you do essentially a coagulation screen, and that will look at lots of different things, protein CNS deficiencies and thrombocyte hypercystinemia, and factor V Leiden, etc., antiphospholipid antibodies, so forth. So that the investigation of kind of these patients are completely different. Homocysteine is what I was thinking, sorry, homocysteine levels. So you can have RVO with high homocysteine levels. And OCT is kind of the mainstay of treatment. So I want to know if there's macular edema or not, and that's a very nice way of doing it. In the picture here, this is not fluorescein angiography, this is OCTA, which is a very nice way of checking the macula to see if there's ischemia. So picture C here, the foveal vascular zone is kind of looking fairly normal. Picture B here looks enlarged and irregular, and then E and F, you can hardly see any kind of vessels. So these are kind of your ischemic patients who are just not going to do that well. And these will be the kind of patients where the macula is flat, you've treated them with anti-VEGF and they still see 660. And when you do angiography or OCT angiography, you will see that they hardly have any kind of vasculature around the fovea. And essentially, the thing that makes you lose sight is either macular edema or development of new vessel disease, as mentioned. So that's new vessels on the disc, elsewhere, or on the iris. It's very easy, actually, to miss iris vessels if you haven't looked at the patient. So it's essential that if you think somebody has retinal vein occlusion, you check the pupil. Obviously, you would have done the vision. But look at the iris before you put the drops in, because once you put the drops in, the iris is dilated, you might miss fine NVI, and you can sometimes see that right at the pupillary margin. So, you know, this is kind of quite a late presentation, and the pressure might be normal. So just because they have NVI, that doesn't mean that they have high pressures. High pressure develops when the abnormal blood vessels clog up the trabecular meshwork. For those of you who can do gonioscopy, looking for NVA, so new vessels in the angle, is also, you know, would be quite useful. Then you dilate, look at the back, you check for macular edema through an OCT, and then look at the disc. NVD, you know, means really bad ischemia, so that often means urgent referral. These should be urgent anyway, but we would want to laser them pretty quick, because if they've got so much anti-VEGF that they've already developed NVD or NVI, we laser the photoreceptors to stop that anti-VEGF drive. And laser can actually ironically make the macular edema worse, but you can start anti-VEGF for macular edema as well. And, you know, probably in a clinical setting, if I had somebody with gross macular edema and NVD eye disease, I would start anti-VEGF therapy first, because I can get rid of the macular edema and cause regression of the new vessels. But long term, so after 3 months, because laser slots are generally quite difficult to get at the moment on the NHS, I'll start lasering the retina in order to get rid of that angiogenic drive. You'd only need to laser the retina if there's new vessel disease. In context of, oh, sorry, there's another video. In context of macular edema for central retinal vein occlusion, we know categorically now that laser does not work for macular edema in CRVO. And that's why they were doing badly before anti-VEGF came around. Prior to anti-VEGF, laser were used in BRVO and hemiretinal vein occlusion. Although I would say it's pretty much kind of, it's hardly used now. Everybody just goes on anti-VEGF. Right, listen to the next video.
Your ophthalmologist will treat your CRVO with a drug called anti-VEGF medication, as well as laser surgery. These treatments will be done separately from each other, and each takes only a few minutes. Anti-VEGF medication is injected into the vitreous, a clear jelly-like substance in the center of the eye. This medication can reduce swelling of the macula, which helps to slow vision loss or perhaps even improve vision. Your ophthalmologist will determine how many injections you need over a period of time, as well as the type and frequency of laser surgery. This laser surgery for CRVO is called PRP, or pan-retinal laser photocoagulation. With PRP, a laser is targeted at many spots all around the periphery of the retina, avoiding the central macula. Many small burns are made to the retina. This treatment causes the blood vessels to shrink and often prevents them from growing again in the future. It also decreases the chances of the blood vessels bleeding.
Right. Okay. So you can see you can actually get some of these videos from American Academy. Clearly, I didn't make them. I couldn't if I tried because I haven't got the IT skills. But I think it's actually quite nice to visualize via animation some of this stuff because when you're talking, it's difficult to try and get everything in via text. So you can go online and actually just look at YouTube and it'll be there. But these are the kind of mainstay of treatment for macular edema. So we've got the anti-VEGF therapy in form of Lucentis and Eylea. One thing we haven't mentioned here is Avastin. Actually, Avastin is used more than any of these drugs in US and most of Europe. In UK, it's mainly the licensed product that we use, and they're very expensive. So these are kind of high cost drugs. But Avastin comes out at a fraction of the cost of this and does just a good job, to be honest. But anyway, that's what you get through NHS. Insured patients get that, but if ever insurance runs out or anything like that, they can go on Avastin if they don't, want to use the NHS. And essentially, the anti-VEGF stuff, so Lucentis Eylea, is given 1 a month for the first 3 months, and then depending on various protocols, you can have treat and extend, you can have PRN where you're treated only when you're active. My preference is obviously treat and extend. We're locally doing a study to see whether we can latch onto that and to do that. But anyway, this is kind of the ideal treatment. And with anti-VEGF therapy, you don't get long-term raised IOP, and they don't tend to cause cataracts. Now, of course, when you inject anything into the eye, mechanically the pressure goes up. And that can cause an issue momentarily, but most of the time it comes down on its own. I have, touch wood, never had to do an anterior chamber paracentesis, but if the pressure goes up massively and they can't see anything, then you might need to do that. But by the time you're kind of readying yourself to do the anterior chamber paracentesis, the pressures come down and they're fine. But I probably wouldn't advocate using anti-VEGF therapy in patients who've had heart attack and strokes because of that theoretical risk with thromboembolic disease. We will never know whether that's a factor, by the way, because the study required to establish that would need so many patients, as the risk is quite low, that no one's going to A, fund it, and B, no one really almost cares about it, if you like. There's just this theoretical risk about it. So if anyone has had serial MIs or CVAs, I tend to shy away from anti-VEGF. And also if they don't really want to come up that often, because anti-VEGF therapy, in theory, you need 12 injections or up to 12 injections, 13, 12 visits in a year. Most hospitals do maybe 8 or 7 or even less, especially post-COVID. So it's quite difficult in real world to maintain good results with anti-VEGF therapy because the patients are not seen regularly enough, as there are so many of them. So where I work in East Sussex, we do something like 9,000 injections a year. And that's not just obviously vein occlusion for everything, but it's quite difficult to keep patients coming at 6 weekly cycles when you've got so many of them. So longer acting therapy like Ozurdex has been developed. That's a steroid implant, which gets delivered into the vitreous. And the advantage of Ozurdex is that you don't need to see the patients that often. So it's meant to be 2 a year, but actually probably more like 3 is what patients need in order to control the edema. But that's 3 injections, and then you need to see them 2 months after the injection to check for pressure rise. They will develop a cataract. So once you've done 2 or 3 Ozurdex implants, cataract will come. You remove the cataract, and then vision gets better, and they'll do okay. So this is ideal if your patient is pseudophakic, so they've already had cataract surgery. If they don't have glaucoma or pressure problems, because pressure problem is an issue with Ozurdex, and a small proportion actually can develop glaucoma. If they've had recent history of heart attack or strokes and you're a bit worried about anti-VEGF therapy, or if they can't attend regularly, then Ozurdex is a really good option instead of the anti-VEGF. There was a study, actually there are quite a few of these that have come out, comparing real world data versus what the trials show, because in a trial setting, everything is so aggressive. And actually, there's not a huge amount between all these, because you can't get anti-VEGF therapy as regular as you would like to if it was in a trial. And then the only other thing to mention for macular treatment, apart from anti-VEGF and steroid, is laser treatment, which is only used for branch vein occlusion or hemiretinal vein occlusion. You need protein angiography, so you know where you're lasering. And what I would say is that, you know, I'll probably use this as adjunct therapy rather than first line, because by the time your patient comes, got macular edema, anti-VEGF is what's going to get rid of it. So it's quite nice to use laser to reduce maybe your dependence on anti-VEGF. But again, as I said, it's rarely used for management of macular edema. And new vessel disease, I've kind of mentioned heavy laser treatment. Here's a picture of a retina that's been lasered to the oblivion, and that's because you need to get rid of that angiogenic drive that the anti-VEGF has, and the only way you're going to do that is with laser treatment. Anti-VEGF therapy in form of injections can also do that, but really primary anti-VEGF therapy, just to get rid of the blood vessels for new vessels, is going to be quite hard to maintain, expensive, and it's not nice approved anyway. So sometimes we do use Avastin. For example, if they come with neovascular glaucoma, you give them injection of Avastin in the vitreous, and the new vessels on the iris regress, pressure comes down, macular edema goes away, and then you can laser the retina. So anti-VEGF can be used as an adjunct in that situation as well. So I kind of mentioned this already. You need to you do your loading dose, which is 1 a month for the first 3 months, and then they're seen every 6 weeks, but depending on where you work, the kind of protocol can be different. You can have treat and extend or other things. Treatment can go on actually. So sometimes you've got some patients can go on for years having treatment. 30%, so 20% I think only have 3 jabs and that's it, but majority will continue having injection therapy on and on and on because the macular edema keeps coming back. And as I mentioned to you with so it's quite a heavy burden on us and for the patients. So Ozurdex in some ways is better if the patient cannot come as often. And as I said, it's meant to be 2 implants a year, but we probably use 3. I wouldn't go more than that for any patient really. And then they need a visit after 2 months to measure pressure, etc. Right, now comes to the cost. So when an NHS, I've kind of adopted this from an NHS op, but anyway, from every visit is probably about 80 to 100 pounds when it comes to what the NHS spends on these patients. The actual delivery of the injection is probably 50, 60 pounds, but the drug cost can vary. Anything between 550 to 800 pounds and 870 pounds for Ozurdex. And I think there is VAT on top of that, I'm not sure actually. But anyway, look, so in a kind of private setting, patients can choose what they want. And often if they're self-payers, we give them all the options, but a lot go for Avastin, which is a very good drug and has comparable data and results to Lucentis Eylea. And if after 3 or 6 injections, they're not getting what they should, we switch. So if I've started on Lucentis, I'll probably switch to Eylea next. And if Eylea doesn't work, then maybe Ozurdex, and vice versa. Ozurdex, probably go to Eylea, and then if not Lucentis and Avastin, if they want to use that as well. So lots and lots of very different trials showing how wonderful these anti-VEGF and implants, Ozurdex implants are. As I said, the main thing is just trying to manage the demand because it is quite heavy work. So a lot of NHS departments have developed ways of trying to kind of manage this by doing 2-stop and just anything to keep the injections going. But sometimes it can be quite hard to do that. Right, and this is kind of the 5-year outcomes of vein occlusion with anti-VEGF therapy. So this kind of tells you really what you need to know in a snapshot. But essentially, if you're going to improve your vision, you will do within the first year. And after the year 1, really all you're doing is you're maintaining your vision. And if you don't treat, the vision goes down again. So, and central retinal thickness, similar, most of the drop in central thickness in vein occlusion, whichever type it is, happens in the first year, then it kind of tails off. So your first year is the best chance you have to get them to the best they can get, which is why it's very important to try and get everybody in ASAP so you can start them as soon as possible to minimize damage. And a lot of patients say kind of, they get really flabbergasted by all the injections that they've got coming. So you're often asked, well, what is the injection numbers over time, etc., blah, blah, blah. So within kind of your BRVO group, over 5 years, they tend to have up to nearly 30 injections over 3 years. And on average, they kind of go around 5 or 6 injections, very similar to CRVO actually. But 10% only ever have 3 injections. But I'd say the majority, I would prepare them that this is not a sprint, it's more of a marathon, and they will be having treatment for time to come. But one thing I can say is that we know across pretty much vein occlusions, diabetic macular edema, wet AMD, if you're going to get better, you will get better in the first year. So that's really important. And the sooner you treat and better your baseline vision, the better you will do. So yeah, so this is something we did locally actually, where I am looking at Ozurdex, and we had some good data over many years. And we found that actually Ozurdex was quite a good. It does tend to get a bit of a stick. I've got no financial interest in Ozurdex, by the way, but it does get a bit of a stick because Allergan, I think in general, are not amazing at doing trials. So they often include patients who are phakic. They will only give 2 implants. So often the vision doesn't look as good as anti-VEGF therapy. But actually, if you look at the pseudophakic group or group after cataract surgery, and if you try and do 3 implants in a year, the results are not too different. And I'm not taking anything away from anti-VEGF, is very good, but I just think monthly injections are very hard. But the main thing is you always let the patient know what the choices are and they make a decision. So as I mentioned to you, if they're pseudophakic, glaucoma, can't come to hospital quite a lot, Ozurdex is a very good option. If they are phakic, they can come to the hospital regularly and they don't have risk of cardiovascular issues significantly anyway, then anti-VEGF is ideal. That's kind of the way I divide it. So my main advice to you before breaking out, I don't know what's the time at the moment, is, so I'm sure we have some questions in a minute, is to refer anyone with retinal vein occlusion as urgent. Include as much information as possible. So often people say, oh, can you see this patient with retinal vein occlusion? And you can't really triage that. Although the vision's there, I'd want to know, is there an RAPD? Is there macular edema? Because I'd say majority of opticians now have an OCT. And, is the contralateral eye involved or not? And is there any new vessel disease? Those are the kind of main stuff. I don't really expect everybody to say patient's diabetic and has had glaucoma and the father has this and the mother has that. Just the basics of what we went through would be quite useful. So we can triage how quickly we need to get the patients in. Although, again, as I said, probably not much of an issue in a private setting because they get in quite quickly. We would then ask them about the medical issues. I would write to GP to investigate those. And of course, generally the rule of thumb is that if they've got new vessel disease, you need to laser them. But if there's macular edema involved as well, probably we start off with anti-VEGF therapy and then laser comes after. Very important also to note, one disadvantage with Ozurdex therapy is that it doesn't cause regression of blood vessels. So if you're going to treat them with Ozurdex, that won't address the abnormal blood vessels, the new vessels. So you would have to think about doing the laser as well. Okay. Any questions? I'm going to stop share. I can see like 18 at the moment.
Thank you, Shah.
Yeah, sorry, you went again.
Thank you. That was brilliant. We do have quite a few questions, as you can see.
Was it very quick? Was it very quick?
It was great. We've got time for questions now.
Yeah, that's fine.
A lot of questions are based on referrals. So you mentioned urgent or see soon. It's quite nice to have a time frame when you say.
I think I would want any RVO, I'd want to see within a week.
Within a week?
Yeah, so you'd want to see them within a week to get the OCT done and start anti-VEGF therapy. There really isn't much point. The only time I've ever procrastinated with respect to anti-VEGF therapies, if they come, there's a little bit of macular edema, but vision is 6.5. They don't have symptoms. They're asymptomatic. Probably get them back in 4 weeks. Start off all the bloods, obviously, because, you know, just because they, you know, if they've had RVO, then you need to look at the bloods that I mentioned, depending on if it's bilateral, unilateral, or what age they are, to avoid it coming in the other eye. That's very, very important. But if the vision's good, there are no symptoms, or the macular edema is abutting fovea, but it's not involving the foveal area, and they want to wait, then we can wait. But I always scan them within 3 to 4 weeks just to see how things are going, and warn them with an AMS degree that if the vision gets worse, they should come. But yeah, a week is probably as much as I'd like to wait before I see one of these.
Any of them required same day? Anything that we see clinically that we need to send them the same day?
Yeah, so I think, I think you would refer the same day anyway. And if there is capacity, we would want to see them straight away. But so I think if the question is, what would make me think, oh gosh, I need to see this now, is if they've got new vessel disease. I mean, macular edema in time will get bad. It's not like wet AMD where they could suddenly lose vision. But you definitely want to get onto treatment ASAP. I mean, we've got this NHS kind of rough guide of treatment within a month, but I wouldn't want to wait for a month. I mean, you know, if you're going to treat straight away. So, but capacity is a big problem. And in an NHS setting, we try and get them in within a month. But if they've got established macular edema, you might treat sooner than later, and a week would be fine. Anyone who would want to have like treatment there and then, like sooner than that, would be if they have new vessel disease. Because if they bleed and if they get a vicious hemorrhage, especially if they have new vessels on the disc or on the iris, then, you know, you may lose the boat with treatment. So if they've got iris vessels, pressure goes up, then you can't laser. If new vessels at the back of the eye on the disc in particular, because that means high risk of ischemia, then they can get vicious hemorrhage and then you can't laser, you've kind of missed the boat. So those ones I would see pretty quickly.
Thanks, Shah. How about if in clinic we don't see macular edema, but obviously there is a vein occlusion? What do we do then? Do we send off for bloods? Do we send them to you?
Yeah, so I think, yeah, no, we would want to see. We definitely want to see. So I think we would, yeah, exactly. So I think what we'll do with that, if there's no macular edema, but there's vein occlusion, you need to investigate. And that's very important, blood pressure and all the things we've mentioned already. And I would probably just rescan them again in about a month to 6 weeks, unless they get symptoms, they must come. Unfortunately, patients won't necessarily come unless you actually say to them, look, if the vision goes down or if you get distortion, you must come. They tend to kind of wait until the 6 week comes. But I would stress to them that they should attend as soon as anything changes.
And Shah, for example, for these patients that we aren't sending within a week, so let's say we're waiting for them to go to you because they're not as urgent, what are the particular bloods that we could ask the GP to run? So if you could you do a cardiovascular screen for atherosclerosis? That would make them do probably a full blood count, HbA1c and a lipid profile. But if you've got somebody who is in the age range group, so over 50, unilateral, you know, and they have hypertension, etc., you would probably want to do a full blood count, ESR, HbA1c. Those three you have to do, and a 24-hour tape, which a lot of GPs don't have time to do that, so they get them to get a blood pressure machine, etc. If it's bilateral, then I will send in because the list is quite long. So you need, and it should be more of a specialist request because we need to organize coagulation factors, you know, ANA, serum ACE, VDRL, all these things. So we would probably want to see bilateral cases anyway. So I probably wouldn't bother. But in the setting, if you wanted to write to the GP, those are the things that they could do. And actually, by the time they come to clinic, then we have that data already. So if they're younger than 50 and bilateral, probably just send it urgently so we can have a look. So just to reiterate this, an asymptomatic patient, but who we happen to find a BRVO, do we still do an urgent referral?
Well, urgent referral as in I would refer the same day. What I wouldn't do is in a community setting, sit on that and wait to see whether anything develops, because you need to still exclude the risk factors and just.
So a lot of practices won't have a pathway that we can send these to. So when you say refer same day, do you mean off you go to A&E?
Well, no, I mean, almost every area should have a kind of a rapid access clinic. So we certainly have here. I mean, so I would probably fax a letter or email the letter to the GP to pass on to the eye department. I don't think A&E is going to be the right setting because they're not going to be able to see the back of the eye anyway, and there's not much they're going to do in A&E. It needs to be an ophthalmic review. So I'll go via the GP if you haven't got one. So we would get them. So the community optoms would fax us to the retina emergency email here, and we will go through that. But yeah, I mean, I think I wouldn't wait. I wouldn't sit on that, because if there are underlying issues and then the other eye gets involved, then we're in a bit of a tricky situation. Treatment-wise, you're right. So if there's no macular edema, you might not think, right, I'm going to kind of do anything with this right now, but you should look at risk factors. So look for new vessels, look for pressure problems, look for, is there anything that could make the other eye go likely, etc. So I would send the referral from the community the same day, and then include all the date information I said. What's the vision? Is there RAPD? Are there deep intraretinal hemorrhages, cottonwool spot, anything in the medical history that worries you? Because they would have had the vein occlusion for a while. So when the eye department gets that, then they can triage that with that information. Otherwise, if you just write, can you see this RVO? It's going to be very hard. So in fact, we do get referrals like that. And I normally, first thing I do is put them through a virtual OCT, which we can do within a week. And then that way I can decide how quickly I need to see them.
How do you know how long it's been there? Obviously, some people turn up, some patients will turn up and say, oh, this vision's been poor for a while. Well, how do you decide how long it's been there for? And does that affect your treatment?
No, not really. So I think one thing I would do is I would probably look and see, well, so if the hemorrhages have resolved and then you've got perivascular sheathing, you've got collaterals, then you know this is like 2-3 months at least. I don't think anything would affect my treatment for macular edema with anti-VEGF therapy unless they were horrendously ischemic. So you come with hand movement vision and not much macular edema, then not much hemorrhage, I'll put them through fluorescein angiography and establish that there's massive ischemia and probably talk them out of anti-VEGF. But I think if they come with significant macular edema and they're not ischemic, or even if they're ischemic but have okay vision, I would give them anti-VEGF, because we know from trials that if you delay anti-VEGF by longer than 3 months, then they won't do very well. So you need to treat within 3 months. But I'm not at all suggesting if you've got macular edema, wait for 3 months. Treat as soon as you can, but you definitely don't want to go past that target. So if they are ischemic or non-ischemic, but they've got good vision potential, as defined by presence of RAPD, deep intraretinal hemorrhages, cottonwool spots, all those things, then I will start anti-VEGF ASAP.
Thanks, Shah. We've got a couple of questions about the newer anti-VEGFs that are coming out, the BOVU. Oh, BOVU.
So they're not licensed, as far as I know, at the moment for RVO. BOVU in particular, at the moment, we are, locally here anyway, we're thinking about the incidence of intraocular inflammation. This is something that we don't see as much with Eylea or Lucentis. And I think BOVU is fine, I think, but we need just to understand how the intraocular inflammation comes into it, because about 5% of patients can get vasculitis and they might then need treatment of the vasculitis. So I think we need to understand that. But yes, definitely an option. BOVU should definitely be an option. There's also these new reservoir kind of implants that are being discussed at the moment, where you can essentially put an implant underneath the conch and they fill it every 6 months with anti-VEGF. Again, that's being discussed and is going through the various regulatory protocols. What would be lovely is to have an implant like Ozurdex that will release anti-VEGF rather than steroid, but they haven't been able to do that. So I think at the moment, the mainstay of treatment is, you're right, I should have probably mentioned BOVU as well, but I think because he wasn't licensed just yet for RVO, as far as I know, didn't mention it. So you've got the main anti-VEGF panel and Ozurdex and laser, and that's it for now. People have tried surgery and fenestrations and things like that, but I'm not aware of any particular success rates.
So Shah, I just would like you to summarize. So with all, even small branch retinal vein occlusions, you want to see them. We should send them in, right? We shouldn't manage this via a GP. you would want to see them?
Yes, I think so. So I think you need to monitor them, and you need to minimize the risk of the other eye having it. So I think what I wouldn't do is if it's incidental finding, you send a routine referral to the GP, or you send the referral, and the GP will look at it, pass it on to the eye department. You need to include, oh, your vision is fine, patient didn't know, there's no macular edema, there's no RIPD, blah, blah. And then the department, or wherever you set it, can triage. Obviously, as I mentioned, in a private setting, because there's capacity, you can see them straight away. So you wouldn't make them wait. But in an NHS setting, that is important, because when capacity is limited, you have to know how to triage these things. Otherwise, you can't treat every RVO the same, because you'll miss the ones you need to see urgently, and you see the ones that you need to see kind of maybe in 2 or 3 weeks in a week, and that's not great.
Okay. You talked about the risk in the other eye. So although one eye might be minorly affected, what is the risk of getting it in the other eye?
5%.
Okay.
So 5% have bilateral disease. And certainly if they present with bilateral disease, then, or if they're young with unilateral disease, then you need to throw the book at them, because you need to see why that's happening.
I have a question about, what if a patient has a dense cataract? How do you assess for macular edema if the OCT image is very poor?
That's actually a very good question. So what I would suggest with that is the 2 ways of doing it. If the cataract, what you want to do is to stabilize the retina before you do the cataract surgery. So I wouldn't rush in removing the cataract without stabilizing the retina. Now, if the cataract is not dense, if it's dense but you can see macular edema, then you can use your anti-VEGF, or probably anti-VEGF, to try and flatten the retina, as long as you can see what you're doing, because the OCT is fine. If, however, the cataract is so dense that you can see RVO, but you can't see the macular edema, well, you can remove the cataract and do anti-VEGF at the end of the surgery, so same time, and then go aggressive. Or you can use Ozurdex and then do the surgery 6 weeks after, because the peak with the Ozurdex is different to anti-VEGF. With anti-VEGF, the peak is after 7 days, and then maybe goes a little bit and then starts to come down by 4 weeks. With Ozurdex, the peak is between 6 to 8 weeks. So when you implant the Ozurdex, the ideal time to remove the cataract won't be straight away, it'd be 6 to 8 weeks. Probably what I would do is, if I've got a very dense cataract, I can see hemorrhages and I'm worried, I remove the cataract so you can see what's happening on the back of the eye. And if I'm convinced that the hemorrhage looks like RVO, then I'll probably give them an anti-VEGF as well.
What are the further risk factors of doing that cataract surgery whilst I've had a newly acquired occlusion?
Sorry, the risk factor would...
Any further risk factors when you...
Any other risk factors for what? Doing the cataract surgery? Well, no, I mean, if they've got a dense cataract to the point that you can't see the back of the eye, you need to remove the cataract. So it would be difficult, I'm sure, but I wouldn't treat it as any different to any other dense cataract. Probably the only thing I would add would be the anti-VEGF at the end of the surgery, just to, in case there's macular edema. But ideally, if you have got somebody with a significant cataract and a retinal condition, you should initially stabilize the retina, and stabilize to a point that the retina has been very quiet for 3 months. Then do the cataract surgery, because that's going to set off the retina. But that's not always possible, as you mentioned. Sometimes you can't see the back of the eye. Sometimes it's really difficult, so you'll have to kind of seek expert opinion to how to manage it.
How about unilateral tortuosity of blood vessels? Is that an impending RVO?
I think with RVO, I'd want to see retinal hemorrhages. So I think if you've just got tortuous vessels, first of all, there's a condition called FRAT, I think, familial retinal tortuosity, FRAT or something like that, where you can just get tortuous vessels without it being anything genetic. Hypertension, previous vein occlusions, things like that can give you tortuous vessels. To diagnose RVO, you really need to have hemorrhages. And I think if the hemorrhages have gone, then you look at the disc and see if there's any collateral vessels. So if you're just seeing tortuous vessels, then, and there's no hemorrhages, no collaterals, no perivascular sheathing, then you'd question whether an RVO occurred or not. Even
if it's unilateral?
Yeah, unilateral, you'd want to know why though. So I would again send it in for investigation, but lots of different things can give you that. but it wouldn't be like a super urgent referral, and it'd be unlikely to be RVO if there's no other features of that.
We'll go with a few more, a couple more maybe. Which that's an interesting one. The risks you listed before: hypertension, diabetes. Is it still specifically worth discussing to the patient lifestyle changes to assist in helping settle the RVO or the edema, or is it all medical intervention?
Yeah, no, I mean, I think if they've got badly controlled diabetes or hypertension, you would want to manage that medically, but that's why I would leave the GP to do that. So sometimes you don't know the patient's diabetic. Sometimes the GP does a blood pressure and it's super high. So often by the time they come to eye clinic, they've had that all managed. But I think the eye follows almost a separate pathway for treatment. So if there's macular edema, we don't really need to wait until the blood pressure, the diabetes, we just do our own bit and the GPs kind of manage their bit. But it's important because you can get it in the other eye. So it's important to pick on that and make sure that all the issues have been addressed to minimize the risk to the fellow eye.
Shah, can you just briefly discuss what we might see if a patient's had a resolved occlusion? So if they come to see us, we know they've had a past occlusion.
So the main thing is presence of collaterals. I would also look for prevascular sheathing around the veins, so these white lines around the veins. Tortuosity, which you mentioned already. The other thing to see is when you do an OCT, you will see thinning of the retina. So if it's a BRVO, you might see one side kind of quite thickened and the other side quite flat, no edema, and that's often a sign. So if you don't see that green donut and you see just green at the bottom and not at the top, that would make you think whether there's been a previous occlusion. That can be arterial or venous, but generally arterial occlusion tend to have a lot more symptoms, pale disc, etc. You don't tend to get that with a venous occlusion. Yeah.
Great. I think we're going to leave it there unless you've got something else to add, Shah. I'm just going to run through this poll. If you want to read through the questions, I know you like to have a little look at them and see if there's any particular ones you want to add. I am going to launch the polling. So if you could all please fill in this reflection statement if you can. I know some phones or however you're viewing it don't allow you to, so don't worry if you can't. But for those of you that can, feedback's always very welcome.
But are blood thinners a risk factor? So that's quite a good question about blood thinners. So whether they need a blood thinner or not, that would depend on the medical risk factors. So I think if they've got high risk of atherosclerosis and a blood thinner is required, the GP can start it. We would then give somebody a blood thinner if they've had a venous occlusion. So it's not like pulmonary embolism or DVT where you give them a blood thinner because they've had an RVO, because the mechanics are completely different. In retinal vein occlusion, it's because the artery and the vein are very intimately kind of close to each other. And, when blood pressure goes up or, you get atherosclerosis, the vein collapses and that causes an issue. So, and if they're on a blood thinner, I wouldn't stop it either. So I think that hopefully answers that one. What do you expect the retinal thickness to be after a vein occlusion? Well, I mean, I think it'll just be thinned. What you need to do is to compare it to the other eye. That's often rather than an actual value. So the question is, if somebody has a BRVO, what would you expect the retinal thickness on the OCT to be? It's just thinner than the other side. So look at the other side. Look at if it's a branch, look at the other half. It will look different. So your OCT will just dip, and that's often the thing. I think.
Thank you, Shah. I've just ended the poll, so I think we are good to go.
Yeah.
Thank you so much for today. It's been fantastic. I really have learned a lot, so much appreciated as always.
Thank you. You take care.
Thanks everyone for joining. We'll see you soon.
Bye. Bye-bye.